Hi, I'm Dr. Sara Nick-Rivan. I'm a cardiothoracic anesthesiologist, intensivist, and point-of-care ultrasound specialist. One of the main reasons I use the butterfly IQ when I'm in the ICU is try to help understand why my patients are hemodynamically unstable. One of the common pathologies we see is septic shock, but septic shock has different stages. So I have to understand if my patients are in the under-resuscitated stage of septic shock, if they've been adequately resuscitated and now they're vasoplegic, or if they have developed cardiomyopathy and that's why they're in septic shock. So I can use the butterfly IQ by going to the cardiac preset. I'd select the preset button and we're going to pick cardiac because this is a normal-sized gentleman. My go-to view really is the peristernal short axis view, so I'm going to take the probe, I'm going to place it in the 3rd to 4th intercostal space with the orientation marker pointed towards the patient's left shoulder, and then I'm going to slowly scan down the chest until I get to the mid portions of the LV. And what I'm looking for here is to understand if the LV is thickening and approximating appropriately, because if it is, then I know that this patient doesn't have cardiomyopathy as the reason for their shock. The other thing I'm looking to see is if this is hyperdynamic LV function, and the LV is basically obliterating an end systole. Because if it is, then I have to ask myself, well, is the patient under-resuscitated or are they vasoplegic? The next view that I'll go to kind of help differentiate that is the subcostal 4-chamber view, where you're basically looking with the probe in the palm of your hand about 2 finger breadths below the xiphoid, and you're going to take the orientation marker and put it to about 230. But you have to remember that this is going through the liver, this view is, and so you have to increase the depth and give yourself just a little bit more depth. And also because we're looking a little bit deeper, sometimes you have to adjust the gain distally, which we have the capability of doing with this device. So I'm going to just increase the gain distally here. Just by sliding the spar over. And as I do that, you're going to start to see the image a little bit more clearly distally. And from here, you're looking at the RV to see, does the RV look normal in size or does it look dilated? Does it look hypertrophied? Is there some sort of pathology there? Because if there is, then you know you won't really be able to trust the IVC for your assessment of volume status. But if it looks good here and there's no bad tricuspid regurgitation, you can just take your probe, rotate it to the 12 o'clock position, and when you do that, you're basically going to get the IVC into view here. And if the IVC looks small and collapsible with respiratory variations, then you know your patient will likely respond to fluids. If the IVC is big and dilated, greater than 2.2 centimeters, and not really collapsing with respiratory variations, then now you know you need to start vasopressors. So in just a few minutes, you've figured out why your patient is hemodynamically unstable and able to direct your care. That's how I use the butterfly IQ when I'm in the ICU.